Healthcare-associated infections. Prevention as medicine. My name is Erin King, and I'm a nursing student at Indiana State University. The population at risk for this presentation are any patients receiving treatment in a healthcare facility. I ask that you pause the video at this time and take the pretest. What are they? Healthcare-associated infections are acquired by patients while receiving treatment for a medical condition. Healthcare-associated infections can quickly become a major complication, leading to an increased level of care need and an increase in healthcare costs. Healthcare-associated infections increase morbidity, which in turn increases length of stay, potentially worsens prognosis, and increases mortality in patients. Healthcare-associated infections represent a public health problem worldwide. About 4% of patients hospitalized in the United States have at least one healthcare-associated infection. In Europe, this figure is about 6%. Studies have shown that implementing prevention methods can reduce incidence of healthcare-associated infections by up to 70%. Common types of healthcare-associated infections. Advancements in healthcare have developed many types of invasive devices that aid in the patient's recovery and improve patient outcomes. However, just as with any invasive procedure, infections can be attributed to the use of invasive devices. These types of healthcare-associated infections include central line-associated bloodstream infections, catheter-associated urinary tract infections, ventilator-associated events or pneumonia, and invasive and surgical procedures that also may lead to infections. Surgery sites that become infections are known as surgical site infections. Prevention measures for clinicians for central line-associated bloodstream infections. Follow proper insertion practices. Perform hand hygiene before insertion, adhere to aseptic technique, and use maximal sterile barrier precautions. Prepare the insertion site with greater than a 0.5 chlorhexidine with alcohol. Place sterile gauze dressing or sterile, transparent, semi-permeable dressing over the insertion site. Handle and maintain central lines appropriately. Comply with hand hygiene requirements and use only sterile devices to access catheters. Bathe ICU patients greater than 2 months old with a chlorhexidine preparation daily. Scrub the access port or hub with friction immediately prior to each use with an appropriate antiseptic. Perform routine dressing changes using aseptic technique and replace dressings that are wet, soiled, or dislodged. Change gauze dressings at least every 2 days or semi-permeable dressings at least every 7. Change administration sets for continuous infusions no more frequently than every 4 days, but at least every 7 days. Promptly remove all unnecessary central lines. Prevention measures for clinicians for catheter-associated urinary tract infections. Insert catheters only as appropriate and leave in place only if needed. Minimize urinary catheter use and duration in patients, particularly those at higher risk for catheter-associated UTIs. Avoid use of urinary catheters for management of incontinence. Consider using external catheters as an alternative to indwelling urethral catheters. Use urinary catheters in operative patients only as necessary, rather than routinely, and remove the catheter as soon as possible. Intermittent catheterization is preferred as opposed to indwelling or suprapubic catheters in patients with bladder emptying dysfunction. In the acute care hospital setting, insert urinary catheters using aseptic technique, sterile equipment, and provide routine aseptic catheter care. Prevention measures for clinicians for ventilator-associated events or ventilator-associated pneumonias. Avoid intubation if possible. If able, use non-invasive positive pressure ventilation. Minimize sedation necessary. Manage ventilated patients without sedatives whenever possible. Interrupt sedation once a day and assess readiness to extubate once a day. Pair spontaneous breathing trials with spontaneous awakening trials. Patients are more likely to pass a spontaneous breathing trial and be extubated if they are maximally awake at the time of the breathing trial. Maintain and improve physical conditioning. Provide early exercise and mobilization. Early exercise and mobilization speed extubation, decrease length of stay, and increase the rate of return to independent function. Minimize pooling of secretions above the endotracheal tube cuff. Provide endotracheal tubes with subglottic secretion drainage ports for patients likely to require greater than 48 or 72 hours of intubation. Elevate the head of the bed, 30 to 45 degrees. Maintain ventilator circuits. Perform oral care with chlorhexidine. Administer prophylactic probiotics as ordered. Prevention measures for clinicians to prevent surgical site infections. Administer antimicrobial prophylaxis according to evidence-based guidelines. Begin administration within 1 hour before the incision to maximize tissue concentration and discontinue agent within 24 hours after surgery. Do not remove hair at the operative site unless it will interfere with the operation. If removing hair, do not use razors. Use clippers or hair removal agent such as depilatory cream. Control blood glucose and maintain normothermia in postoperative period. Administering supplemental oxygen during and immediately following the surgical procedure optimizes tissue oxygenation. Use an alcohol-based skin prep prior to incision and educate patients about surgical site infection prevention as appropriate. The Targeted Assessment for Prevention Strategy, or TAP. The Targeted Assessment for Prevention Strategy is a framework for quality improvement developed by the Centers for Disease Control and Prevention that uses data for the prevention of healthcare-associated infections. The TAP strategy is a 3-step prevention method. Running TAP reports in the National Healthcare Safety Network to target healthcare facilities and specific units with an excess burden of healthcare-associated infections is the very first step. The second step is administering TAP facility assessment tools to identify gaps in infection prevention in the targeted locations. The final step is accessing infection prevention resources within the TAP implementation guides to address those gaps. As a clinician, where can I find more information? Internet resources provided here are healthcare-associated infections, which is a link to the CDC, additionally a link to health.gov, as well as Healthy People 2020, and AHRQ, which provides tools to reduce hospital-acquired conditions. Thank you for viewing my presentation. I hope that when you're practicing daily, you're thinking about ways to prevent healthcare-associated infections. I ask that you take the post test. I hope you've enjoyed the presentation. Thank you.